really talking about here today, collaborating beyond the hospital. It's really a dual competency. Do you get that patient ready for discharge? Once that patient's ready, do you have them set up for post-hospital care? Do you have the technology set up? Can you flow that data? What is the clinical relevancy that you're looking at to do that? The backdrop to that, what are your payment models? Private payer, admissions, length of stay, readmissions, ED. This is an infrastructure that really has a dual competency around it. So to speak to that today, we have two speakers. And if we go to the speaker slide, we can introduce them for you today, and then we'll get started. Yes, hello. You see, If we go back to our speaker slide here with us today, we see Nikki Buchanan, General Manager here at Philips. And what we're talking about and what Nikki really oversees here is really a connected care platform that really looks at population insights toward care. That platform looks, again, at this dual competency because you need to segment those populations through risk. You need to look at quality reporting. You've got to look at interoperability. Once that patient's in the home or off-site, what is your remote monitoring? What is your medication adherence at home? Can you visualize EHR integration? Define your patient networks. Those are the clinical technologies that we're looking at in terms of establishing that infrastructure for the health system. And Nikki leads those processes here for Philips. We will hear from her today.
Hello, everyone.
Hello. Welcome. Our first speaker here today that will kick us off, Peter Fleischut, MD. As you see his title there, let me also add that he oversees the management of the EHR implementations for the health system, all innovation, artificial intelligence, we'll be hearing about that today. Telemedicine, we'll certainly be hearing about that today, as well as pharmacy and other clinical processes. He's also responsible for the development of the NYP OnDemand suite of digital health services. We will absolutely hear a lot about that today as well. He also oversees the implementation of these clinical operations at the David H. Koch Center at NewYork-Presbyterian, Weill Cornell. Welcome to you both. And Dr. Fleischut, please take it away. I will come back toward the end. We will leave plenty of time for questions. I will come back and lead that. Thank you, Dr. Fleischut. Thank you both.
Excellent. Thank you, everyone, and thank you for that great introduction. I appreciate the opportunity to really talk about some of our work in leading in telemedicine and artificial intelligence, something that really is core to our strategy at New York Presbyterian. Before I go into the specifics and start talking about some of the technology and the innovation, I just want to lay out the framework of New York Presbyterian for any of you that may not be familiar with New York Presbyterian. Here's some basic stats on New York Presbyterian and our 10 locations. We have the fortunate opportunity to have these locations and also to be working in partnership with our colleagues at Weill Cornell Medicine and Columbia Doctors Physician Organization. And there's also a third physician group that is our employed physicians, which is the New York Presbyterian Medical Group. So all in all, there's 4 major groups of New York Presbyterian. There's New York Presbyterian Hospital, which makes up 7 of these hospitals. There's our regional hospital network, which is small and large community hospitals throughout Westchester, Queens, and Brooklyn. And there's the employed physician group, New York Presbyterian Medical Group, and also a group focused on population management, population health. And this is core and critical because as we start to talk about technologies and what I really refer to as these platforms, it's critical to be thinking about how we're using that, especially in an environment like ours, where it's crossing multiple hospitals, multiple physician organizations, multiple areas where we can be reaching patients and be able to take better care of them in their home, in community centers, maybe in one of our hospitals, and really thinking about virtual care in a different perspective. Most importantly, there's a core vision behind where we stand as an organization, and it's really actually made up of 4 major focus areas. The first is standardizing. And this right here, the standardize, regionalize, and virtualize is something that we talk about throughout all of our locations and with all of our 40,000 employees. And standardization is core to what we're doing in making sure that we provide the same standard of care in any one of our locations. And not only in our physical locations, but in our virtual locations. And that goes to a lot of the work, especially we're currently doing right now with implementing Epic. We currently have about 9 electronic medical records, and we're putting in Epic across all those hospitals in about a 47-month project. The second is regionalize. And I'll dig deep on this topic. For example, in each and every one of those hospitals, we may not have the same services, for example, like heart transplant. You can see where you may go to certain hospitals or certain provider organizations and follow up with a primary care or cardiologist and maybe get a cath procedure. But then you may go to one of our other facilities and actually be able to get a TAVR or a valve replacement. And ultimately, if you needed a heart transplant, you may only go to one of our sites that provides heart transplants right now. And that's what we mean about regionalization, so that we can be able to provide care locally, but also can be able to provide a higher level of expertise in various hospitals. And the third is virtualize. And we look at this in 2 major ways. At NewYork-Presbyterian, we really feel that it is core to our strategy to be leading in telemedicine and artificial intelligence. Most of the talk today is really about telemedicine, and it's really about transformation and change for us as an organization, so that we're not requiring people to come into our practices or needing to be in every facility or having to go from one to another, or taking care of people in homes or in a nursing home or in a local Walgreens. Wherever it may be, we want to be able to bring the care to them. And I'm going to talk more about that throughout the presentation today. So now I'll talk about our virtualization strategy. And I mentioned the word NewYork-Presbyterian OnDemand, and a lot of people ask, well, what is that? So historically, we have not focused a lot on telemedicine in the past. Many great institutions have been doing this for many years. Some actually, reports have been going back 40, 50 years where telemedicine was being used. And about 2 years ago, it was the leadership of our board of trustees and our CEO, Dr. Corwin, that really charged us with thinking differently about the use of telemedicine, remote patient monitoring, and AI. Very quickly, we took a look at the market and looked at synchronous telehealth, asynchronous telehealth, remote patient monitoring, and quickly came to the realization that there was a lot of great opportunities, but it was of a lot of siloed services, things like second opinions or remote monitoring or video visits. And as an institution, we wanted to provide a comprehensive suite of telehealth services so that we could be able to provide, the ability to get a second opinion across the country, or the ability to do remote patient monitoring in a patient's home, and use that as a platform. And that was our focus. And this was back in about 2016. And so we've been at this for about 2 years now. And there's 3 major focus areas. We wanted to be able to improve access. We wanted to make it easier for people to get access to urgent and primary care and specialty care. We also wanted to really improve outcomes, especially with certain disease states and conditions. And ultimately, and still working on this, is making sure that we are reinforcing that this should be cost reducing across a system and to patients. And many of you know on this webinar, that's a very challenging thing to do and to prove, but one of our core focus areas. Commonly in this process, we've hosted, I think, around 60 or 70 health systems on site, really working collaboratively together, what's working, what's not working, what are new technologies or new processes coming out that could help us further this vision. Ironically, the first question I always get is what technology you're using or what platform, and 9 times out of 10, it's less and less about the technology. This is really about adoption. These technologies have been around for 30 and 40 years. There is no doubt that the infrastructure and broadband has come to a whole new level in our country. But to really adopt these types of strategies, it's about change, and it's really the people. It's the world experts at Columbia or Cornell. It's about changing the process, and it really has not much to do with technology. We're in a day and age where everyone now has a smartphone and the ability to do FaceTime, and even FaceTime with up to 30 people at once on a phone. And we're a very connected society. So it's about how do we take those technologies and really how do we embrace the future moving forward? How do we lead the change and change our processes to adapt those technologies? And I won't talk about artificial intelligence that much, but that's actually, as an organization, we focus on. We're using AI throughout everything from back office to clinical operations to diagnostic and imaging. Where we actually focus our energy is not on the application or implementation, which is going really well. It's more on the retraining of the workforce. We see there's an ideal opportunity for our staff and our processes to be supporting training entry-level workers, food and service, nutrition workers in cybersecurity 101, in automation 101. We even have a Python coding class 101 for entry level for people to really be learning these skills and retrain the workforce and make sure that we're providing everyone the skills and capabilities they need to be prepared for the future. And our HR team has really been leading the way in those efforts. Now, that being said, we do think of ourselves as a platform, and we do think of ourselves as a technology provider, not only a healthcare provider. And that gets to the difference of a virtual platform, which gets to what I would call scale and speed. So when we are not physically constrained from building a new hospital or putting up a new location, and we have the capability of using platforms like telehealth, it allows us to scale at an exponential rate. So what do I mean by that? In 2016, when we started the program, we did about 1,000 telehealth visits. And in 2017, we did about 10,000 telehealth visits. And we just finished this year and for 2018, and we did about 125,000 visits. And for 2019, we're projecting somewhere between 500,000 or 1 million visits. And it will continue to go on from there. So this provides the capability for us to be implementing 1 to 2 new services a week, to be doing thousands of visits a day, and to be doing them in New York State, across state lines, throughout the country, and even throughout the world. So I'm now going to talk to you kind of a brief overview of these suite of services and the way that we look at providing care to the communities we serve. The first on the left is the second opinions. We're very fortunate, the world experts at Weill Cornell that we have and Columbia doctors. That being said, it's hard. It's hard for patients to travel, to give up work, to pay the expenses of traveling. Even if you live right in the city, it's expensive to go to see a provider. And so we wanted to provide a platform so that in any one of 46 states, you could go online, you could be able to request a second opinion, and we have over 400 experts in 80 specialties. And a team will go out and collect the medical records, and then they will then surface that to the expert. If it's an oncologist or urologic surgeon, whatever it may be, get it to the right expert. And in about 24 to 48 hours, we render a second opinion directly to that patient. We've been fortunate to be able to have situations where somebody is diagnosed with stage 4 cancer, not wanting to proceed to surgery because of concerns of going on to dialysis, and going through the process and finding that we could be able to connect them to a surgeon that could be able to do the operation and not have to have them go on dialysis. And ultimately this individual decided to say, yes, I'm going to go ahead. They flew out, had the procedure, and ultimately were able to, not have to be on dialysis because of the concerns of the surgery. And, in rough numbers, we've been fortunate with that platform on the outcome side. About 22% of the time, the diagnosis is changing, and about 60 to 70% of the time, the suggested treatment is changing as well. So this is a great opportunity for us to be able to take, expertise that is really a challenge to be able to get access to and be able to make it so it's available to more people. The second area is in our emergency departments. Our emergency rooms, as most throughout the country, are very congested. There's a lot of people there. It's a really great opportunity for increased throughput, increased patient satisfaction. And it's an area where we focus a lot of our time and energy on telehealth, and I'll talk about it more in a minute. But we came up with a concept of being able to, when a patient comes in and seeing someone in triage, and if it's low acuity, a upper respiratory infection, a GI illness, a wound, a scratch, whatever it may be, asking a patient if they would prefer a video visit with a provider right away, or would they prefer to see somebody in person. And this has been a big advancement for us. Traditionally, the in-person visits from admission to discharge take anywhere from 2 to 2.5 hours. With what we call express care, patients from admission to discharge, it's about 31 minutes. And I'll walk through that process, but just on the outcome side, on the process side, it's a huge advancement in the turnaround time for a patient to be able to come in and be seen by a board-certified emergency medicine physician and be able to go home. Now, we didn't want and have this just in our emergency rooms. We wanted to provide this capability on patients' phones so that they could do this just from their home in, Connecticut, Florida, New Jersey, New York. And so the same capability is available just on our phone, and we try to strive to have a provider available in about 90 seconds so that you could basically see that same exact provider just from your home and not actually have to come into the hospital. It's not all emergency and urgent care. We provide this in all of our departments, anything from integrated wellness to primary care to cardiology to neurosurgery to follow-up visits and the like, so that you could basically be able to have that capability when you're seeing your primary care doctor, or when you're seeing and having a follow-up with after a minor procedure. So you wouldn't maybe need to give up a day of work or have to find parking or wait in an office. You could just do a video visit right from work or from your home or whatever is most convenient. The fifth area is what we call specialty consults. And specialty consults is, I think, like the part of telehealth that's been deployed a lot of hospitals, and the original is the telestroke, where patients had the ability to come to an emergency room, and if unfortunately they had a stroke, and there was a neurologist that wasn't immediately in the emergency room, to basically connect back to a neurologist via telestroke. And that program in itself saves about 7 to 8 minutes per patient. And as we all know, that's about 2 million brain cells a minute. So about 14 to 16 million brain cells being saved for a patient by the ability of providing a neurologist immediately available. Going back to the layout of New York-Presbyterian, this is critical. We have multiple different places where people could be coming into, multiple emergency rooms, and really needing to get to a neurologist quickly. And so that's why telestroke has been core to us. But as we started that, we thought there was other specialties that were critical to expanding this out. So we actually provide telepsychiatry to our EADs. As we all know, psychiatrists, and especially pediatric and adolescent psychiatrists, are in very shortage. And so by providing telepsychiatry, we now have a hub of psychiatrists so that you can connect. If you come into any one of our EDs, be able to get to a psychiatrist within about an hour, where traditionally in some of our community hospitals, it would take up to 24 hours. And you keep on going down this with telepediatrics and other teleservices providing hospital to hospital. The last kind of specialty consult, which we're deeply invested in is, we think that telestroke is critical, but we want to take it a step further by actually having a mobile stroke unit. And that mobile stroke unit is actually an ambulance with a CAT scan in the ambulance. And I'll show some images of that later. And this is when a patient calls 911 and they're having signs or symptoms of a stroke. And we actually dispatch the mobile stroke unit, and we go to their home, and then we bring them in the ambulance, the patient, and do the CAT scan right in the field. And the intention is that if it's an ischemic stroke and we can be able to diagnose it in the field and treat the patient with TPA to open up the blood clot, we can actually save a substantial amount of time. And we save anywhere between 50 and 60 minutes per patient, so 100 to 120 million brain cells for a patient having a stroke. To me, this is transformative in the ability for us to treat people at their home, in their driveways, at work, wherever they may be. And then we are able to bring them in and take care of them. In some instances, we've had patients recovering from the symptoms of the stroke before they even got to the ED. The challenge with it is it's a very hard model to scale because the neurologist needs to be on board every mobile stroke unit. So what we did was we actually got 2 additional units. There's only, I think, 12 in the country, so we have 3 of them. And we run this fleet of mobile stroke units across Queens, Brooklyn, and Manhattan. And we run it with one neurologist who is able to do telehealth across multiple ambulances. And so we recently had a case where actually 3 patients were actually having strokes simultaneously, 1 in each mobile stroke unit. And that neurologist was able to intervene and be able to take care of all 3 of those patients and getting that expertise at their homes or work or wherever the ambulances were. Now, all of that, I think, is core and was core to our strategy for the past 2 years. And one thing we didn't do was invest in remote patient monitoring. We're very focused on taking kind of the best practices in telemedicine and scaling them. But for remote patient monitoring, we weren't really at that point of ready to start that process. And now we are. And we've recently, in working in conjunction with our colleagues at Philips, basically started that process, realizing now we're able to do the visits with patients. We're able to have a new care model where we can do and see people at home. Now we are thinking, okay, how do we get the correct vital signs to complement all the information and being able to connect with the expertise so you can even do even more in the patient's home? And I'll talk about that in a moment. This is just a brief layout of the second opinion program. And as I mentioned, it's a pretty simple process. It takes a matter of a couple minutes. It's online, and it's our ability to go out. And like I mentioned, we do this in about 46 states. And it's a great platform to be able to get connected to the world-class expertise at Weill Cornell Medicine and at Columbia Doctors. And we've been very, very happy with being able to do that. And the second opinions really do come throughout the world, throughout the country, even locally, patients who prefer to more interact with this type of platform. And these are just representation of, we have it available in 46 states, but we've really been able to complete second opinions all throughout the country. Now, this is my example of when I talk about our emergency departments. None of us want to have emergency departments that look like this, and I'm sure at times many of us do, who's on the phone, that are providers. And this is a challenge. And the emergency rooms can be very, very cyclical, especially around flu season. And what we really would love is to be able to have emergency rooms that look like this and that are spaces that are open, not congested, that are comfortable for our patients. And that's why we came up with the concept of express care. And this was the comment that I mentioned earlier about the ability. So take, for instance, this patient coming in and having to, let's say, get a wound check or some condition. And it just so happens that they came in and they're seen in triage, and it's a low acuity visit based on certain criteria and algorithms that we've created. We give them the option, as I mentioned before. If you'd like to stay and meet in person with the provider, or would you like to go in this room here and you can sit and there's nice 2 chairs and a table and you can see the provider on the other side, and very specific equipment. We work with Avizia, now American Well, on this, where those cameras can be able to zoom in to a level and a detail that can be able to look at a fingernail, and those patients are able to now interact with that provider. The first thing people say is, well, wait a minute, this feels kind of artificial. Nobody wants to be talking to a screen. But I'll be the first to say, when you're in this room, it is like no other experience in an emergency room. There's no background noise. There's no pagers going off. And you really have one-on-one dedication between the provider and the patient. And it's a kind of a surreal experience because you really have their dedicated attention to be able to interact with that patient and with that provider. Now, when we started this, a lot of people thought that we were crazy because this provider and this room are separated by about 20 feet. So a lot of people would say, why in the world would you have this provider not just come and meet the person in person? And that's a really good question. And the answer is she probably could. The reason why we set it up this way was we felt that it was actually going to be extremely successful. We started and we did the first 50 patients in July of 2016. And it turned out so successful that patients absolutely loved it that we wanted to be able to scale it. And so 2 weeks later, we went to our hospital in Lower Manhattan. The only difference was we didn't replicate the provider. We had the same provider being able to do video visits to our other hospitals. So all we needed to find was a room and a nice table and chairs and a process and work through with the staff. And now they're able to do that work basically by having this one provider providing multiple care to multiple sites. It's kind of like the analogy of why would you have a teller or an ATM machine in a bank when you have a teller? And I'm sure at some point and someday somebody said, why in the world? I'm just going to go to the teller. And at least for myself right now, for simple things, I go straight to the ATM and definitely don't go to the teller even if I'm going into the bank. Now, as I mentioned, our goal is not to have patients coming into the emergency room. Our goal is actually to make it as convenient as possible. And this is one example. In our NewYork-Presbyterian app, we provide the ability for patients to connect to their provider or connect to urgent care, primary care, or pediatric care. And this is the ability of them to be able to do that in any one of 4 states. So it's critical for us to make it almost that convenient. So I hope to be a day where, maybe the patient doesn't come to the ED and they actually just interact on their phone and they see the same exact provider and can see it on their phone. Now, that being said, we didn't really want to stop there. We felt that it's critical that it's in a phone, but we think that patients may differ in the way that they want to interact with or access these services. So, for example, we actually have this pre-installed on Samsung phones throughout the country, so you can get on a Samsung phone and get the same access. You could also, some people may use like ZocDoc, and they'll be searching for an appointment, finding a provider and a list of appointments of providers where they can see those providers in person. Well, we actually work with ZocDoc so that when you go online and search, you can actually just connect with one of our providers and do a video visit through ZocDoc as well. And our other collaboration is actually one that we're very proud of, is the ability to actually even go into a physical location. So there's 8 Walgreens that we have throughout the city and the boroughs to basically be able to go in to see one of those providers. And not only, you go in and you sit and there's a kiosk in the Walgreens and Duane Reade, and what it allows you to do is you can go in, you can get your blood pressure checked, your heart rate, your oxygen level, your temperature, and basically be connected the same way immediately to one of the providers. I'll give you an example. This is one of our patients. This is Ron. And Ron is walking one day to work. He's in his 40s. And Ron wasn't feeling too well. It'd been about 9 years before he had seen his provider as primary care specialist. He was a little short of breath. Well, Ron actually walked to one of our locations at 40 Wall Street. And it turned out that his vital signs were a little bit concerning, and he had the fortunate opportunity to be connected, and ironically, he was connected to our chairman of the emergency medicine department. And he immediately said, and assessed Ron and did a virtual a physical exam with various maneuvers and said, Ron, I'm a little concerned. I'm going to have you go to our emergency room at Lower Manhattan. Well, it turns out that Ron actually had undiagnosed congestive heart failure, diabetes, and hypertension, and actually got admitted and was in the hospital for 3 days, and now subsequently has been discharged, treated, and is doing much better, no longer with any heart failure. All his conditions are being managed, and Ron has lost about 40 pounds. This is a very serious condition that Ron was in, and his vitals were very concerning at that time, and he didn't even know because he didn't have any other symptoms. And the comment that we make is, Ron kind of walked in and, pressed a button and got immediately connected to the, chairman of emergency medicine. It's kind of the equivalent of you going on your 401k plan and calling the toll-free number and getting Warren Buffett on the other line. So all joking aside, it's really about providing access to providers. And so that was a great opportunity for Ron, and obviously being able to connect with all his subsequent providers and then being able to take care of him afterwards. I mentioned specialty consults. This is the traditional telestroke. This is the telepsychiatry work that's being done, telepediatrics. These are all critical conditions that we just want to make sure that we get the best expert to any one of our facilities, and this is something that has expanded. We're one of the first to be doing telebehavioral health and are very happy with it, and patients absolutely love it. It's one where I actually wasn't sure that they were going to like it because of the underlying medical condition, but they actually really do engage and like the process of using the telepsychiatry. Once again, we wanted to take that kind of to the next level, and this is an example where we have patients that are extremely sick and they are in our hospitals and they get discharged, and we are very concerned with them just because of the underlying conditions. Take, for example, a patient with heart failure. So in some cases, what we do is we actually schedule a teleparamedic visit 7 days out from their discharge. So as you can see here on the right, this is a patient in their home that has been discharged and is now home, and we send a paramedic in the home and we do a video visit back to the core team with the ED team and the heart failure team so that we can adjust medications, adjust any thing in the home, or help them, or maybe need to give them a treatment to help them so that we can be able to keep them in their home. And so if you think of the mobile stroke unit as a very capital intensive, you need a CAT scan on all the ambulances, the teleparamedic is a much easier lift for us to be able to see these patients in their home. So that being said, this is our mobile stroke units, and this is what I was mentioning before with the ability, if you're having a stroke or signs or symptoms of a stroke, you actually, if one of these ambulances is in the neighborhood, they get deployed to your home, and you can see the patient on the left, and that CAT scan is actually in the ambulance. And that is done, and then that's transmitted back to a neurologist, and it's assessed, and the neurologist is directly monitoring the whole process via video. And so telehealth has enabled us to basically be able to run a fleet of these ambulances and really provide that expertise and those good outcomes throughout the boroughs. And that brings me to the last component of this, is around remote patient monitoring. So as we start to really accelerate our virtual care and basically accelerate the ability for us to connect with people in their homes, on their phones, in Walgreens, on iPads, and in all these different venues, it also allows us to put other providers and make easier access to providers like a pharmacist who can do telemedication reconciliation, or a lactation specialist, or a nutrition specialist, or genetic counselor. And as you start to do this, there's a critical need to now start to really need more things in the home. And this gets to the remote patient monitoring program. So working with Philips, being able to monitor someone's blood pressure, oxygenation, or be able to do a direct video visit is core and critical to us as an organization and needs to really be scaled exponentially. So a couple of the areas that we're starting in is the traditional heart failure and COPD conditions where we feel that extra level of monitoring is critical to keep the patients in the home, to take better care of them, to optimize their medications. And also in maternal care. So high-risk mortality is high-risk patients, pregnant patients, is critically important to us as an organization. And maternal mortality is a major issue. So this is one where we'd like to focus a lot of our time and energy on looking at hypertension, diabetes, and being able to provide a patient that's going through that process with even more touch points to the system, like the ability to monitor vitals and be able to do video visits with our providers. And this is a major focus for us in 2019 and moving forward, so that not only can we be able to provide a new care model with the ability of pharmacists and providers doing, telemedicine, but also remote patient monitoring as a complement to that. And ultimately, more things will come along with the ability, as Greg mentioned, I'm responsible for pharmacy, and being able to get medications delivered to their home, and really excelling and accelerating our efforts to be able to take better care of patients in their home. So I'm really proud of the efforts that has been done to date. That being said, this has really been a massive collaboration with a lot of health systems throughout the country. I think we're continually learning best practices. There's a lot of challenges associated with this. I didn't touch on the regulatory, the reimbursement, the licensure issues associated with doing this, and those are a lot of things that we've had to overcome. As an organization, really this is critical as a high-functioning team to make sure that we have everyone from the clinical teams, the operations teams, finance, strategy, marketing, communications. Every piece of our organization really had to come together to provide these level of services and be able to provide them to their patients and in home. And as well as very much strategic partnerships with organizations like Philips to really help teach us what's the best way to be able to do this and do it in their home. So with that being said, I'm fortunate enough to be able to hand it over to Nikki at this point, and excited to hear the next steps.
Thank you so much, Dr. Fleischert. And obviously, all of our listeners can hear directly from you that you have really taken this transformational shift in patient care delivery to a new level. And depending on where you are, listeners, you may find yourself being more on the left side of this delivery care model, where it's still very much tied to the hospital system or network, or you may find yourself somewhere in between, being able to be totally patient-centric as you see the NYP team has evolved. And, I think they got there through the leadership of folks like Peter on the call. They had the vision, they got the buy-in from the clinicians, they spent time redesigning workflows and educating. And then we've had this perfect storm in the past 2 years with CMS looking for new ways to reimburse all of these types of telehealth and remote patient monitoring type visits. And it really takes all of these things coming together to really lend to this transformational shift and this improvement in care. Obviously, Peter shared with you, they've been able to implement things like telestroke, telepsych programs. And what they're really doing is they're improving the access to care. They're improving the quality of care that their patients are receiving. And in return, they're gaining even more stickiness, right, with their patients because of the improved satisfaction and ways that they are reaching them. They're engaging with them and putting them at the center of their care and allowing them to access care and through remote capabilities. Because of it, they're seeing a reduction in their crowded ERs, and they're, of course, being innovative in the way they're redelivering care in their ERs. They're reducing readmissions through these processes, which will ultimately have an impact on cost and the total clinical cost. And last but not least, you also heard they are very strategic in their partnerships. Folks like Walgreens and Boots are allowing them to have care delivery opportunities in their pharmacy. They're partnering with ZocDoc to continue to allow these remote patient visits to occur, and ultimately shared partners that Philips also has, like American Well, to increase that just typical PCP type visit with their patients. So overall, they're seeing improved clinical value for their patients. And these are life-saving value opportunities that are just fantastic. So I'm so happy to have him share these stories. Additionally, how we're getting there with NYP, go ahead and advance to the next slide, please, is we're allowing and working together with NYP across their 9 institutions and their varied settings across America to bring that data together. What we are doing is taking the claims and the clinical data and providing business insights, business intelligence around the best ways to pick the right populations and the right cohorts. We can do that through tools and technology that allow us to do high-risk scoring of patients, risk stratification methods, etc. We can also look at pharmacy data and help improve the information about whether or not medication adherence is happening in the homes. We can also provide the vitals and key pieces of information when a patient has been discharged and is going about their daily activities, and provide specific touch points for patients who are dealing with comorbid conditions. So overall, you can see by connecting the data, not just in the healthcare setting, but also at home, we're able to provide the right type of intelligence for focused comorbid patients to be cared for in the long term. Next slide, please. And of course, it's with this combination of this accessible data that we're allowed to take the insights needed to provide it back to the clinicians so they know where to focus. We can spend time or decrease the time in where our customers can spend on their care gap identification. And of course, we can help them coordinate their care internally with the hospital settings or with the remote settings, all increasing the ways we activate, engage, and work with the patients so that we have the right focus on the patients in these programs in the future. Peter mentioned that they're focusing on these OB/GYN patients in the future. Well, in combination with the COPD and the CHF programs, which are just standard programs for Philips through our connected care ecosystem, we're also able to customize programs like this OB/GYN program. And we've spent the past 4 months or so redesigning a program specifically with NYP to address that specialty need. So I ask you, those of you that are somewhere in this world of creating your digital health strategy, what programs are you going to focus on? What programs and insights are you going to have at your fingertips to pick the right patient populations and cohorts? And if you're not sure exactly about how to go about that digital health strategy for which patients will provide the best opportunity for your telehealth programs, reach out to folks like us at Philips who can help you, or share, as Dr. Fleischert mentioned, through other opportunities with other health systems to learn from them. We've got a lot of history, over 10 years of history, working with these telehealth programs, and we love the opportunity to share our knowledge, our insights, but we also love the opportunity to craft new programs with you that are focused on your initiatives. And last but not least, as we wrap up the webinar, of course, we believe at Philips we are totally all in on connecting the ecosystem of our providers, our provider networks, as well as our customers' ecosystem. So we will take the time to spend with our customers and create the right type of strategic vision and plan. We will bring together the data through connected systems, through aggregation and patient segmentation. We'll spend time with you understanding your care coordination programs or your strategies. We, of course, will look for opportunities for you to re-engage with patients long-term, or just on short visits when necessary. And of course, we will continue to partner with our customers to provide the right types of insights, dashboards, and analytics that tie together the access, the quality and the patient satisfaction that our customers are looking for. Because ultimately, we agree with Dr. Fleischert. To get to the care transformation goals that we all have within healthcare, we must be able to have a vision, work with our clinicians, provide the right types of incentives for them to be successful, and of course then bring the programs that are at the heart of clinical transformation in combination with our partners to deliver the right type of clinical value, long-term life value that increases patient satisfaction. So thank you so much for Dr. Fleischert for sharing your story. Thank you for being a transformational partner with us. And I will now turn it over to Greg because I know we've had some really interesting questions come in.
Thank you, Nikki. Thank you both for that presentation. Yeah, we've got about 10 minutes till the top of the hour. So we'll delay, and I'll relay questions as they have come in out to both presenters. The first one, Dr. Fleischert, for you. Do your physicians providing their time for telemedicine, are they doing it as part of their call requirements? If so, are they billing for this time, or are they being provided with a stipend or any internal compensation? I'll actually follow on that too, but that's for you, Dr. Fleischert.
Great. So there's no one specific answer for that question because in total we have about 700 to 800 providers that are providing telehealth in the various settings and scenarios. So on short, there is not really like an on-call or non-on-call. You know, it may be a provider that is seeing patients in their outpatient offices that are scheduling a couple of their follow-up visits being done via telehealth in place of the original follow-up visits of the patient coming in person. And then there's things like providers or mid-levels like pharmacists providing telemedication reconciliation as a part of the responsibilities of their role, and they're actually doing it as a full-time role and doing it hour after hour, so it's just a part of how they're paid. So, you know, and there's very different models of either 24-hour services or providers that are using it as a part of their everyday operations and just really integrating it into their workflow where they're giving patients the option to be able to be at home and see and take care of patients in their home.
Okay. You both touched on this during your presentations, and we all know that the physician fee schedule from CMS for 2019 has 3 different fee reimbursements for remote patient monitoring. And for the first time ever, they've struck down originating site requirements to really open up and expand telehealth for, as you put it, mobile stroke units, ESRD, and the telestroke. These are actually billable fee reimbursements now. I'm sure you put your program together prior to this. It started January 1st. Will you start billing for these? Have you? And how much motivation is really there, just given this new fee structure?
Yes, it's something that we've been very thoughtfully following to make sure that we're prepared and we have all the right processes, policies, and procedures, and following it. So yes, eventually we will. And to your point, we did start a lot of the program in a setting where it was not so clear if reimbursement was going to happen. So we just felt it was critical to the communities we serve, to the populations we serve, and frankly, we had to learn how to be able to do and to work in this operating model. It is a completely different framework. So reimbursement is one component of it. And it is one that if we felt we waited for, we would be woefully underprepared to be able to operate in this environment at the scale we wanted to. We do not and we will, but there are so many other components to this too, because as you can start to realize, it's the reimbursement, and as I mentioned, it's the licensure, and it's following the state-by-state guidelines of what happens where and how to approach it. And we really went through a very thorough process and a regulatory process to make sure that we're following the laws, especially in areas where there was none, and then they were created. So we have a whole team and a governance structure that follows this and follows it on a weekly basis to make sure with the amount of programs we have that we follow that work.
Gotcha. Another question, I think, 2-part for both of you. You talk about segmentation, you talk about risk. Nikki, how does your platform drill down into risk and segmentation to match that to the patients NYP wants to reach? And then either or, the other part of that question is, what equipment is needed to start a telemedicine program for video visits for the physicians and for the patient video room? I hope that's not too jumbled in there for you.
Sure, great. I'll take the first and a little bit of the second and let Peter elaborate. On the first, we use Johns Hopkins risk stratification tools embedded in our platform, in our architecture, to really drill down to the patient level. But of course, we combine it with what clinical programs our partners are focused on. So if they are tied to a value-based care reimbursement program or a commercial payer contract, and they want to focus on certain things, we will take that cohort of patients and then ultimately generate a RUB score based off of all the clinical and claims data that we have across our partners' ecosystem. So we can score patients, provide that information to our clinicians, and then let the clinicians obviously do the next step around care coordination. And of course, ultimately, we try to work with our customers on which patients to focus on to deploy the telehealth programs. We have 10 years of history that show if you focus on COPD and CHF, you are hitting those really high-risk patients that are high cost, but you're providing alternative solutions in a lower reduced risk setting as well as a financial setting. So history tells us that's where you start. OBGYN works great for NYP because, again, they've got long-term history with patients who have comorbid conditions like diabetes and hypertension. And again, we can serve up that data to say, this is exactly the area, location, and groups that you need to focus on for these telehealth deployments. When it comes to the technology, Dr. Fleischert mentioned you can do it as simple as using FaceTime, right? If you want to start low-key, low-tech with your clinicians and your providers, but obviously when you want to think about a long-term digital strategy that could be reimbursed by CMS, then you need to follow a lot of the rules, the deployment rules and deployment methodologies, and that's where certified vendors like ourselves, with our FDA, approved products, and American Well, our partners, can really help provide that security as well as conform to the CMS standards that are being requested for by these health systems. Dr. Fleischert, do you want to elaborate on that at all?
No, I think you covered it very well. You covered it, and that's exactly it. I would say the one thing that we did when we considered going into telehealth, we actually looked at a lot of technologies. We looked at our internal capabilities. But the other thing we did was we met with the leadership of the whole hospital and patients and nurses and everyone. And we actually found that it was interesting when we asked people about what should we do with telehealth. We actually came up with about 25 to 30 different problems. And what that actually did for us was actually helped us hone in on what we really wanted to do and what we were really focusing our efforts on. We were trying to grow, we were trying to improve patient satisfaction, we tried to improve efficiency for our existing patients. So I will say that, in even the specific question of video visits in the ED, there's multiple different reasons why you may want to do this. And so, yes, you can be able to have the video technology and, use the Cisco, which we chose it because we chose American Well, but the underlying Cisco infrastructure because of the reliability. But it really was important to us to figure out what problem we were trying to solve and what process we needed to do this. We use another workflow in the EDs where we've actually decreased our time to provider by about 50% using video visits in the ED as well. So I would just push you to think through the exact reason why you're doing this and then be able to find what's the best technology and the way that you need to use it. But overall, the costs are definitely low, and there's, I think, a big gain and opportunity for it.
Okay. Let's do one more. We're about there, but I think these are going to be relevant for everyone. Dr. Fleischert, for you, have you, in fact, realized reduced hospital readmissions related to these interventions? And do you have any data yet, or do you have a sense about patient adherence to long-term remote monitoring in their home?
It's two great questions. One, I think across our interventions, we've seen reduced readmissions, especially with some of our work in the teleparamedic work, where we're really seeing high-risk patients and keeping them in their homes. As you know, we've just started the collaboration with Philips, and we're early on in the journey. And so with long-term remote monitoring, we've not seen that, only because I think we've really just started this journey together. But my anticipation really is that the data actually has been proven out in heart failure and COPD. Where I look to ourselves is we just really need to operationalize and scale some of these opportunities for patients and making it as easy as possible for them to benefit from it. And from that, I think we would see some of the benefits that have been seen in other studies.
Yes, sir. Gotcha. Let's wrap at that. We're just a minute left until the top of the hour. Thank you all for staying with us on the line.